Hi everyone, welcome back to class. In this video, we are going to finish up the dopamine hypothesis. So in the last video, then we talked about the dopamine hypothesis 1.0, but after a lot of the research was done on this subject, then we've actually updated the dopamine hypothesis. So the dopamine hypothesis 2.0 came around a few years after the first hypothesis. And remember that the first hypothesis said that schizophrenia results from excessive dopaminergic activity, specifically in the mesolimbic pathway. Well, after doing some research, then we've been able to adjust our hypothesis to say that schizophrenia results from a combination of subcortical dopaminergic hyperactivity and cortical dopamine hypoactivity. Okay? So we get excessive dopamine in the subcortical areas, but not enough dopamine in the cortical areas. So these revisions were made after many studies that conflate psychosis with schizophrenia. So psychosis is certainly associated with this dopamine dysregulation. So we looked at right here, we looked at this mesolimbic dopamine pathway and how we get some of those positive symptoms from excessive dopamine activating the nucleus accumbens when it should not be activated. And then dopamine dysregulation and this psychosis represents the cumulative results of both genetic and environmental changes to our neurobiology as well as that neurochemistry. Now, other neurotransmitters are also implicated in this pathway. So, for instance, glutamate and GABA are upstream from dopamine in the mesolimbic area or in the mesolimbic pathway. So perhaps it's dysregulation of GABA and glutamate that's leading to this dysregulation of dopamine. That's something that we have to research more. The current antipsychotic treatments, though, tend to actually focus on the downstream changes in dopamine rather than focusing on the primary abnormalities, so those other neurotransmitters upstream, so potentially the GABA and glutamate. So these antipsychotics target postsynaptic dopamine signaling, while dopamine dysfunction likely emerges due to that aberrant presynaptic regulation. So I'm going to bring up this slide again. So antipsychotics act right here, blocking the dopamine from entering the nucleus accumbens, whereas schizophrenia itself is most likely actually due to the excess release of dopamine here. So perhaps we should actually be blocking the release of dopamine rather than focusing on blocking the binding of dopamine. Okay? Now, the presynaptic dopamine also lies downstream of those other changes in, say, GABA and glutamate and other circuit changes. So again, perhaps we should be focusing more upstream and not on that mesolimbic dopamine pathway specifically. Perhaps that's a side effect of the actual cause of schizophrenia. So due to all these things, we've actually then come up with the dopamine hypothesis 3.0. Now, this is the hypothesis that we are currently working with. And this one came out in about 2009, so you can see that we're still working on it. But the dopamine hypothesis currently says that schizophrenia results from a combined genetic and environmental insult that results in altered neurodevelopment, including subcortical dopaminergic hyperactivity and psychosis. Okay, so we're saying that genetics and environment leads to a change in your development during that adolescent period that leads to schizophrenia, and one of the main symptoms or results of this altered neurodevelopment is the hyperactivity of dopamine in that mesolimbic pathway. Okay, So like I said, there are other neurotransmitters associated with schizophrenia. So there are atypical antipsychotics that address other neurotransmitters, or they do something other than have an activity on those D2 receptors on that postsynaptic cell, specifically in the nucleus accumbens. So some examples would be clozapine, risperidone, and quintiapine. Common binding sites for these atypical antipsychotics is the serotonin 2A receptor. The atypical antipsychotics do tend to have reduced extrapyramidal side effects and are more effective against those negative symptoms. So remember, the negative symptoms would be those depression-like symptoms, and the typical antipsychotics really only focus on the positive symptoms because they're focusing on that excess of dopamine in the nucleus accumbens, which is associated with those positive symptoms. So by targeting, for instance, serotonin receptors, then we're able to block some of the positive symptoms, but also some of those negative symptoms. Now, another type of atypical antipsychotic would be aripiprazole, and this is actually a partial agonist at the D2 receptor. So rather than being an antagonist that's going to block it, it's actually an agonist. So it actually increases the signaling at that D2 receptor when there is low dopamine tone. So this would be where we're looking at where there's actually a decrease in dopamine function in the cortex, right? So remember, we have an excess of dopamine in the subcortical areas, but in the cortex itself, we actually have low dopamine. So what this atypical antipsychotic is doing is trying to increase the dopamine in that cortex. It also then reduces signaling at the D2 receptors where there is high dopamine, so in the mesolimbic system. So we're decreasing the dopamine in the nucleus accumbens while increasing the dopamine in the prefrontal cortex. And that's how this specific drug kind of works. And the idea then is that it's going to decrease those positive symptoms while also decreasing those negative symptoms. Now, these partial agonists, so like this drug, acts as an agonist, but it actually elicits a less than complete activation of the target receptor. So instead of acting like a full agonist, it kind of only partially, you get from the name partial agonist, it only partially activates it. So that means that you don't need as much dopamine to then trigger those D2 receptors. Okay, so you're going to be able to increase the signaling when you have lower levels. And that's just how all partial agonists work. Okay, so what about the glutamate hypothesis? So this is looking at some of those other neurotransmitters, especially those upstream from the mesolimbic pathway. So many antagonists like ketamine and PCP are antagonists of the NMDA receptor, and they produce positive and negative symptoms. Well, NMDA receptors are not associated with dopamine, they're associated with glutamate, obviously. So how is it that these antagonists create positive and negative symptoms if they're not directly affecting the dopamine? And this is where the theory that something's happening upstream from that mesolimbic pathway is occurring. So one drug, haloperidol, which is a first-generation antipsychotic, actually increases our NMDA receptor density, and that also then increases the extracellular glutamate concentrations. And by changing these functions of glutamate, we see a decrease in these positive symptoms. So again, this is an antipsychotic that's not targeting dopamine. It's targeting something upstream from there. So these elevated glutamate levels are then reported in patients that take antipsychotics. So even if they're taking an antipsychotic that targets dopamine, we still see elevated glutamate levels. So again, it's suggesting that it's not just the dopamine that is causing these symptoms in schizophrenia, that there's other ones involved. Now, there are multiple genetic risks that have been associated with excitatory synaptic function. And remember, glutamate is an excitatory neurotransmitter. So if we have too much excitatory synaptic function, perhaps that's a genetic risk. Now, when you take an oral administration of glycine, which is a NMDA receptor coagonist, then it's actually reported to improve negative symptoms in patients. So here we're seeing that glutamate isn't just affecting the negative symptoms, but also those positive symptoms. So we're able to do some animal studies looking at NMDA. So the NMDA receptor 1 partial deletion causes behavioral abnormalities in mice. Okay, and these behavioral abnormalities have a consistent phenotype to when we give mice PCP. So in humans, when we give PCP, then it evokes these behaviors or these symptoms that are similar to positive symptoms of schizophrenia. But in mice, obviously, we can't ask them, are you delusional? Like, do you have these delusions? Do you have paranoia? Do you have hallucinations? But we can still look at their behaviors. And so by removing the NMDA receptor 1, then we're actually seeing very similar phenotypes as when we give them PCP, suggesting that the deletion of the NMDA receptor 1 is involved in schizophrenia. Okay, now when we treat these mice that have this receptor removed with atypical and atypical antipsychotics, we actually see an improvement. So we actually see them responding to these antipsychotics in a similar way to human patients. When we give them haloperidol, then we see it ameliorates the hyperactivity. So this is a proxy for positive symptoms in an animal model. Again, you can't ask these animal models about their positive symptoms, but what we tend to see is hyperactivity when they're given, say, PCP. And so when giving haloperidol, it seems to reduce this hyperactivity. So it seems to reduce the positive symptoms. And clozapine treatment ameliorates both the hyperactivity and the social deficits. And these are both proxies for the negative symptoms. So again, by using this model of the NMDA receptor deletion, we seem to have pretty good predictive validity. And that's then giving us pretty good face validity. Now, in humans, we do tend to do some post-mortem experiments, respectfully, but we do post-mortem analysis from chronic schizophrenia patients. And what we see is that when we look at the amount of glutamate in their brains, then we actually see that these patients tend to have a decrease in glutamate when compared to controls, especially in the hippocampus and prefrontal cortex. We also see that they tend to have an increase of activity in the glial glutamate transporters in these schizophrenia patients. So they have a decrease of glutamate, which could be a symptom of schizophrenia. Perhaps it's this decrease of glutamate that's causing these schizophrenic symptoms. And then also an increase of activity of the glutamate transporters. So remember, the transporters, what they do is they deal with reuptake. So what glutamate these patients have, it's not able to be as effective because that glutamate's being removed too quickly from the synapses. So it's kind of a double-edged sword. We also see that GABA itself is also associated with schizophrenia, so it's not just glutamate that's upstream, it's also GABA. So remember that GABA is the primary inhibitory neurotransmitter. The receptors are ligand-gated chlorine channels that hyperpolarize the target membrane on activation. So they make the postsynaptic cell more negative. And deficits in glutamic acid decarbolase, or GAD, have been identified in the prefrontal cortex in schizophrenia patients. So GAD is important because it helps transform glutamate into GABA. So if we don't have enough GAD, then we can't make enough GABA. Now what we're seeing is a deficit in both GABA and glutamate in these schizophrenic patients. So here's a fun summary of the different neurotransmitters that have been associated with schizophrenia and how we target them pharmacologically.